All right, so my name is Allan Reiss, and I'm out of Stanford University. I've been there for the last 20 years. Before that, I was at Johns Hopkins University in the Kennedy Krieger Institute for the previous 11 years. So I've only had two real jobs in my life at two places, one in Baltimore and one in California. The weather's better in California, but I liked both places. I got interested in studying sex chromosome variation and its effects on the brain and behavior pretty early in my career. Back in, let's see, I arrived at Johns Hopkins and Kennedy Krieger in 1986, and it was really shortly thereafter that I started doing some work in this area. So it's nearly 30 years, 25, 30 years. And it's been part of a program of work or study that I called behavioral neurogenetics. So trying to understand how genetic variation affects brain and behavioral development and ultimately outcome in human beings. So I think we'll have a little fun today. We have some time. Let's get started. This talk is about Klinefelter syndrome. This is what I was asked to talk about, but again, I have done work in other sex chromosome variation, particularly Turner syndrome, but also in XXX and other variations. I hope at the end of this talk that you will learn about, and for those of you who were at a previous talk, you've already heard some of this at the previous talk about brain imaging methods. And I'll try and tell you how we apply these to Klinefelter syndrome. Give you an idea of our current state of knowledge regarding brain, cognitive, behavioral, and social emotional development in Klinefelter syndrome. Talk about what is now a term that's being used a lot, and you probably have heard of. It used to be called personalized medicine. Now it's being called precision medicine, and how such an approach could actually be very readily adapted to Klinefelter syndrome to potentially improve outcomes. And talk about some new research that we're planning to do at Stanford and have plenty of time, hopefully, for Q&A. Okay, so just for fun, let's have a little pop quiz, okay? And there's no grading on this. It's just a show of hands. And the first four questions are pretty easy, okay? All right, so here we go. Genetic variations in human beings are very rare. Raise your hand if you think that's true. Raise your hand if you think that's false. The falses have it. They're extremely common. Most of the genetic variations we don't know about that we pretty much all carry. I carry a recessive form of a genetic variation for what's a type of anemia or thalassemia, and really only affects me if I get up to really, really significant heights. And actually, you know, I went up, what is that place? I did my internship here in Denver, and there's a place in the Rockies that you can go up, and it's, what's that? Estes Park. So I went up to Estes Park. I didn't feel so good up at Estes Park. So it can't affect me if I ever wanted to climb Mount Everest or something like that. But so there are all these, we all carry genetic variations. And we may know about them and we may not know about them. And we may only know about them if they come out under certain conditions of bodily stress, cognitive stress, physiological stress, and so forth. And Klinefelter syndrome, XXY, is a very common genetic variation. 1 in 500 males, if you think about that, that's very common. More boys are born with Klinefelter syndrome every year than boys with Down syndrome. So, very common. Oh, I just gave you the answer to this. All right, more boys are born with Klinefelter syndrome every year. Raise your hand if you think that's true. All right, good. I'm not going to get, all right. Brain imaging research is primarily a technique to read people's minds. Raise your hand if you think that's true.
But if we wish it was
Raise your hand if you think it's false. That's right. It's been you know, described in the lay press as a mind reading technique, and oh look, we can see what people are thinking about or dreaming about. It's not even close to being there, so let's not worry about that. And it couldn't read my mind. Every time, I think Armin said this too, every time I get in an MRI scanner, I like instantly fall asleep. So I'm a terrible subject for functional MRI or studies. I mean, they just will see me sleeping. Okay, precision medicine. allows doctors or other health providers to provide more effective and targeted treatment based on an individual patient's genetic, medical, and environmental information. Raise your hand if you think that's true. Yeah, and that's really the future of medicine. It's not, in particular in my field in psychiatry, and I am a board-certified adult and child psychiatrist. I've done training in neuroscience and neurology and genetics as well. But in my field, primary field, we need to do a lot better than we're doing right now with our current diagnostic terminology, which are really just umbrella terms. And we'll get back to that in just a minute. Okay, here's our fifth question. What's more important, nature or nurture?
Yes.
Okay, raise your hand if you think it's all nature. In other words, it's all genetics, biology. Raise your hand if you think it's all nurture. Genetics and biology are not important. Yeah, this is a very well-educated audience. Okay. It's, of course, both. It's always both, whether you're talking about even if you're talking about genetic disorders that have much more severe consequences than Klinefelter syndrome, the environment and aspects of the environment can have modifying effects on those outcomes. So clearly, always the case, the two work hand in hand. Okay. Is the human brain dimorphic? Meaning, if you look at individuals who have male sex, XY, and versus female genetic sex, XX, are those brains different? Raise your hand if you think yes. Raise your hand if you think no. Actually, they are different. And it's not different in terms of something you would look at and from the doorway go, oh, that's a female brain, that's a male brain, but they are different. You can find differences fairly easily, and this is a replicated finding across studies. So I'm sure you've heard this before. I'm going to go over this pretty quickly. We'll talk about the basics of Klinefelter syndrome. Obviously, it's due to an extra X chromosome in a male, and this is just a picture of it. It's the most common sex chromosome condition. Physical characteristics include testicular insufficiency, tall stature, gynecomastia, et cetera, often, if not most of the time these days, requiring testosterone therapy or replacement therapy. And here's the area that we're very interested in, which is what are the cognitive, behavioral, and social emotional consequences or risk factors associated with Klinefelter syndrome. In other words, because this is a variation that we can identify, and by the way, why do we know about Klinefelter syndrome? Why do we know more about Klinefelter syndrome than other genetic variations, perhaps? Because it has physical features that allow us to say, oh, you know what, I wonder if that child has, because of this language learning disability, has Klinefelter syndrome. We test them and we identify it. So these areas include language problems, executive function problems, symptoms of ADHD, social emotional problems. We'll delve into this a little bit more. Depressive symptoms. And I want to tell you as a psychiatrist, and this is kind of where I think my additional training comes into play, I really hate the DSM diagnoses. I use them all the time because you can't get reimbursed. I work in an institution, so it never reimburses me, it reimburses my institution. But I use them because it's a way that physicians and mental health professionals communicate with one another. It's a way to bill insurance. And probably most importantly, it's a way to obtain services for children with X and Y chromosome variations that you might not be able to ordinarily obtain just by saying someone has Klinefelter syndrome. But do I think these diagnoses are helpful in terms of describing what actually occurs along with or risk in Klinefelter syndrome? No, I don't. I think ADHD is this gigantic umbrella, and depression is, even less precise. So, well, oh God, don't get me started on autism. So, what we know about autism is that there are hundreds, if not thousands, of different genetic risk factors that increase your likelihood of developing autism spectrum disorder. And the other thing we know about autism spectrum disorder is that if you carry one of these known risk factors, and XXY is one of these risk factors, always end up as having an autism phenotype or autism profile. You can have a whole bunch of other things, and that applies to these other genetic risk factors that we know increase risk for autism. So it's a very imprecise term. It's useful, again, perhaps for obtaining services, but in the end, I hope, on my deathbed, someone says to me, you know what, we fractionated autism and so forth into all these different subcategories, and we can account for 45% of it, and that leads us to the inevitable conclusion that these different subgroups require different types of treatment pathways. So that's what I'm really, really, really hoping. And I would say that if I said that, and I did say that, 25 years ago in certain institutions, they'd boo me off the lectern, because the DSM was considered kind of the Bible, and still is in some cases. So let's talk about cognitive and behavioral and social emotional issues. So do you know what executive function, raise your hand if you know what if you think you're pretty confident you know what executive function is. So a lot of you are, which is good. So executive function, I'll try and give you an example. So you have your 9-year-old son, and you say, Randy, I want you to clean up your room, take a shower, get ready to go to school, get your homework, put it in your bag, and the school bus is coming in 20 minutes.
Move it.
What's that?
Move it.
Yeah, get going. So, and at the same time, Randy has been, playing on his Xbox, and someone's texting him, a friend is texting him, and, he's thinking about what he wants to have for lunch, and, so there's a multi-stage process. You have to concentrate, you have to inhibit, you have to screen out, you have to organize, you have to have memory of what you've been asked to do and the sequence of what you've been asked to do. All of those are aspects of what we call executive function. So it's the executive in your brain that is helping you presumably organize and implement this type of workflow. And so this is a real issue for individuals with Klinefelter syndrome, for many, not all, but many. And kind of the areas that I've put here, verbal memory, attention, inhibition, all would fall potentially under this broader spectrum or broader heading of executive function. Fine motor function, sometimes gross motor function, can be impaired as well, with some clumsiness and hypotonia and so forth. Higher anxiety and depressive symptoms and greater social problems. So sometimes someone brought up the issue of autism, So if these types of problems, particularly your social awareness of others and your ability to relate and understand what other people are thinking, or even understand what you're thinking and how to relate that to other people, if that's impaired enough, you can qualify for the diagnosis of autism spectrum disorder, but I'm not sure that that's actually all that useful, because pretty much there's a spectrum that you can see across the XXY population of some level of these types of symptoms. Now, my colleague David Hong and I were just in a session where we were talking with men who have Klinefelter syndrome and a few that don't, and we were talking about anxiety and depression, and this is a common issue among individuals who have XXY, that there's a propensity, a risk for having greater anxiety and greater depressive symptoms. And we'll talk a little bit more about that, and perhaps as it relates to testosterone as we go on. So all of this, I think, speaks to the issue of, can we identify who among the XXY population are particularly at risk for these types of problems, identify them early, and have a precision medicine approach to dealing with them more effectively and specifically? And I think the answer actually is probably yes. It's going to take an awful lot of work and understanding, and I'll tell you about some of our work in that area. But early identification and treatment, that's really where the money is. Okay, so let's talk about testosterone, puberty, and adolescence in general. So puberty and adolescence mark this transitional period between childhood and adulthood, and it's involved with immense behavioral and physical change. The terms puberty and adolescence are oftentimes used interchangeably. But really, to specialists, particularly endocrinologists and other people who work in this area, puberty refers to this distinct developmental period within adolescence, during which complex endocrine processes culminate in maturation of your gonads or your sexual characteristics. And changes in these hormones occurring during puberty have very powerful effects, and I think Armin talked about this a little bit on the brain, including circuits underlying cognitive and emotional function. This is not just speculative. We know this. There are these receptors throughout the brain that detect the presence of testosterone and testosterone-like substances, and they alter how the brain develops, connects, and functions. We know this in animals, and we have very strong evidence that that's the case in humans as well. So now maybe you're starting to get the sense that I think when you get testosterone, for how long, at what dose, is probably going to be really, really important. So these effects occur via permanent modification to brain structure, so change in the number of neurons, how the wiring occurs, organizational effects, or through temporary modification of brain circuits. Okay. So if you've been to other talks, I apologize, this is a little bit repetitive. Shanley talked about this in her presentations. Until recently, researchers believed that these fundamental organizational effects in the brain from sex steroid hormones occurred only early in life during perinatal development. And it's now clear that the process continues at puberty when gonadal hormones spike for a second time. So there's not only this early spike in testosterone, which hopefully you can see with you, but there's obviously this later one here. So there are these what we call critical developmental windows in which the brain of human beings, if you're a male, are expecting to see this rise in testosterone. And when the rise occurs, the brain undergoes lots and lots of organizational and structural changes. And when that testosterone is not present during the period, or not present in enough, at sufficient levels, you can imagine that those brain organizational changes might not happen to the level or degree that you would want. So testosterone replacement therapy. Standard treatment, as many or all of you know, consists of TRT beginning at or around puberty to correct for testicular insufficiency and promote the development of age-appropriate secondary sexual characteristics. And these are good things. There have been studies on the effects of TRT in boys and adolescents with Klinefelter syndrome, and in fact, there is improvement in self-esteem and in physical characteristics, and perhaps reduction in some psychological symptoms, and we'll get more into that. But in actual clinical settings, this is one of the more interesting things. The whether to treat, sometimes physicians make decisions about whether to treat or not based on testosterone levels. And you might go to one person who says, yeah, I think we should do it anyhow, even though your testosterone levels are low normal, because your testicular size is such, and someone else say, no, your testosterone levels are okay, let's give it some time. So there's a lot of variation in terms of whether to treat and the timing of that treatment. And that actually might make a difference in terms of long-term outcome in Klinefelter syndrome. Now, amazingly, despite the fact that this is a practice that has been in place in the medical field for decades, there's almost no information about how puberty-inducing testosterone affects cognitive behavioral function, like executive function, or social emotional function, like your awareness of others and emotion processing and emotional stability. There's almost nothing out there. So there's this huge gap in our understanding of TRT effects in Klinefelter syndrome. Now, there's some recent studies that you may be aware of that low doses of androgen, not necessarily testosterone, in young prepubertal children, prepubertal, so not to induce puberty, may improve some outcomes. So my colleague and friend Judy Ross just published a study which I was very happy to be able to help and be included as an author in Journal of Pediatrics, showing that there may be, that 1 out of 5 what we call endpoints. So these are the targets which the treatments are designed to improve. 1 out of 5, visual motor function were improved. And secondary outcomes, so these are things that were not necessarily thought of at the beginning. Some aspects of depression and anxiety were also improved among the group that got the low-dose androgen. Shanley's paper also looked at what we call cardiometabolic outcomes and found reduced body fat in those that received the treatment, this low-dose androgen, but had plus-minus effects on lipids, that some of the lipid measures were better, some were worse. So some other studies, so other things you should know about testosterone that are really, really interesting. And these are more case series descriptions, more post hoc, looking back at medical charts, which is not the best way to show effects, but it's a beginning way. That TRT, testosterone replacement therapy, has a beneficial effect on mood and self-esteem in men who are quote-unquote hypogonadal, whether you have Klinefelter syndrome or not. So that's kind of interesting. There are studies that have also been going on, both in animals and now in humans, showing that, in fact, testosterone may have a protective effect when it comes to particularly depression and maybe anxiety as well, which could help explain why women are 4 to 5 times more likely to develop depression than men. And that's just a fact. I don't think that's a sociocultural thing. I think it's pretty much across cultures and ethnic groups and so forth. Much less information from human studies because it's harder to do studies to look at androgen receptors, testosterone receptors in the human brain, but there have been some done. In both animals and humans, the receptors are found everywhere in the brain, pretty much everywhere, with concentrations in particular areas that you might imagine are pretty important. Areas underlying sexual behavior, such as the hypothalamus, emotion processing, such as the amygdala, and learning and memory, such as the hippocampus, and also throughout the cortex. The effects, what people have found, particularly in animal studies, of testosterone may be quite different depending on the developmental period in which testosterone may be administered, such as adult versus childhood. Testosterone levels, and I think there's some debate about this, can be accurately measured in the blood and maybe saliva. These levels actually in typical development in males have been shown to be associated with maturation of brain circuits underlying cognitive, behavioral, and social emotional function. So there's lots of information tying testosterone to development of the brain, in particular for functions that are important for our understanding of Klinefelter syndrome, particularly executive function and social emotional function. So I would make the case that the more we understand about how the brain develops, matures, functions, and is wired in Klinefelter syndrome is important. But, but of course, it's the whole model here, right? So there's, but I hope you don't take offense at this. I think everything, this is like, if I was a cardiologist, I'd show that, all important factors pass through the heart, right? So, but I think I'm really right about this. Whether you're talking about prenatal environment, whether you're talking about the postnatal environment, whether you're talking about genetics, if your focus is on behavior, cognition, learning, emotional function, we're talking about the brain, right? And so all these different things can affect the brain. And of course, on top of that, in Klinefelter syndrome, you have the relative lowered levels of androgen, in this case testosterone, that can affect all the different aspects of development. We'll come back to that as well. Okay, so how many of you were just in that last talk? Raise your hand if you were in Dr. Resnick's. So not too many, okay. So I'll show you some fun movies. Okay, so what's structural imaging? This is taking a snapshot of the brain at a single point in time It's not dynamic, but it gives you beautiful images, and I'll show you a brain that's being imaged across with pictures going across like this. And that's the eyeball up here, and you can see the fluid in the brain is lighter, gray matter, white matter. It's just, when I first started seeing it, by the way, I had no intention of doing neuroscience and neuroimaging. I was going to be a geneticist, particularly in the area of cytogenetics, and I couldn't get my colleague at Johns Hopkins to do some neuroimaging processing for me, so I said, how hard can this be? It was really hard, but I started to do it, and I thought, well, this is really interesting and an important tool. Now, what we do with those beautiful images is not just look at them on our computer on a light box and say, yeah, looks okay, doesn't look okay. We actually take these pictures and we use computers to divide it up into different tissue types, in this case white matter here, gray matter, which are the neurons, the white matter is the kind of the fibers, the connectivity, the wiring. And we can even get lots of really interesting information about the surface area and about the depth of the cortex and so forth. And all that information can be compared between groups or among individuals so that it's not just a qualitative judgment. I was once told that they did a study among really good radiologists to see qualitatively whether they could judge a tumor is increased or decreased between one time point and another. What do you think the threshold was for them being able to accurately judge whether something was bigger or smaller? What percentage? How many think 5%? Raise your hand.
What's the threshold?
Yeah, what's the percent threshold? Yeah.
Diameter or volume?
Yeah, let's just say diameter. So this is in 2D land. Okay. 30. Yeah, it's about 20 to 30%. So my conclusion from this is I don't want a radiologist judging whether my tumor is bigger or smaller, just looking at it. I want something to measure it accurately, and this is what we do with these scans. We measure accurately, we quantify. Now, this is a relatively newer type of imaging, which is also a snapshot at a particular point in time. It's called diffusion-weighted imaging, diffusion tensor imaging, and variations thereof. But it's the wiring of the brain. So these are all of the fibers that connect those gray matter regions that cross the brain and go up and down and so forth. And it's beautiful, it's gorgeous. And it's not just a perfect, pretty picture. You can actually measure the characteristics, the quantifiable characteristics of these fibers and compare between people and groups. Now, I don't know if we can get sound. This is so much fun. I tried to get sound, but I'm not going to sing it for you. This is functional MRI. So this is, unlike the snapshots of the wiring and the anatomy, this is actually the dynamics of the brain in real time. And we may get sound, we may not. But this is a study that was done in published in 2010, looking at the brain's response to this beautiful music. So we'll see if we can get it to go. You'll be able to see the brain, but I don't know if you'll hear the music. No. So the music is coming on, and you can see these areas of the brain starting to light up. So as it gets red, that means that these brain areas are active. And as it gets yellow or even white, it's even more active. And in this music sample, it has shifting tones and frequencies and volumes, and you can see the brain responding differentially. But what you can see, again, in real time, this is the brain in real time responding to music. We can't hear the music, but you'll just take my word for it. It's really nice music. Here's one other interesting neuroimaging modality, and I'll come back to this in terms of precision medicine and Klinefelter syndrome as we get towards the end of this talk, which is called functional near-infrared spectroscopy. And I didn't even know about this prior to about 10 years ago, 12 years ago. Or what I knew about it is that it was used in babies, premature babies in particular, to measure how well those babies were oxygenating their brains. But since that time, it's really been adapted for studies, particularly not only of babies, but of children and people who have various types of neurological, psychiatric disorders, because unlike an MRI, how many of you have ever had an MRI, by the way? Raise your hand if you had an MRI. I just had one myself for my back, and so I get in there, I fell asleep, which was fine, because it was a structural MRI. I didn't have to do anything. But you have to be really still, right? That's the whole thing with MRI, because if you move at all, and certainly more than once or twice, it messes up the whole scan. And people who are looking at it or measuring it have a great deal of difficulty. Well, this is a technique that actually measures the same proxy of brain activity as functional MRI, but you can do it. We could all be having our dynamic brain responses measured, right? This is one of my goals in life, is to go to the Iowa caucuses and have everyone wear one of these. And then as they shift from one candidate to another, I'll see their dynamic. I'm serious, I really want to do this. And we're doing some, I'll show you some stuff that we're doing with multiple person functional NIRS. But it's high resolution in terms of the timing of how often you sample the information. It's not as high resolution in terms of the spatial accuracy compared to MRI. But we can do simultaneous NIRS and fMRI and actually have the gold standard along with this. But then we can make this ultra portable. So we're using this in ultra portable settings, and I'll tell you more about that later. Okay. So let's talk about brain imaging results in Klinefelter syndrome for a little bit. Not surprisingly, we see correlates of those cognitive, behavioral, and social emotional function issues in regions that show this single point in time anatomical difference. So we see smaller volumes of the amygdala. It's a region that many of you may have heard about. The hippocampus, the amygdala involved in emotions, processing, face processing, understanding social cues. Smaller volume of the hippocampus is a region critical for learning and memory. Of the insular cortex, so we were talking about this earlier. I was talking about this with someone who was attending the meeting. The insular cortex is important for a lot of things, including emotion processing, theory of mind, can you understand other people's thoughts and feelings, but also this concept of interoception, which is not so widely known. Are you aware of your own bodily processes? Am I hungry? Am I full? Do I have to use the bathroom? Am I nervous? Is my heart beating quickly or is it slow? These types of internal processes. This is a region, probably the most important region in the brain for interoception. Here's a study that we did just recently. It hasn't been published yet, so you're seeing it hot off the press. This is the insular cortex right here. So both in terms of the surface area and volume, you see this region is definitively smaller in Klinefelter syndrome. And this is a finding that has been reproduced by several labs now and several times by us. So it's a very strong finding. This is another area of the brain that is smaller in surface area and volume in Klinefelter syndrome. It's called the medial prefrontal cortex. And this is an area that's actually very much involved in theory of mind and your ability to understand social emotional processes and cues in the real world. So not surprising for these two to be potentially coexisting. Now, what about testosterone? This is a study that we did many, many years ago with a fellow by the name of Bruce Bender, who was with I think it's called National Jewish Hospital here. Yeah, and this is a group of individuals who were discovered actually not because they presented to a clinic, but because they did a consecutive analysis of live births. And very exciting study one done here, I think a couple done in Europe. We only had 10 subjects with Klinefelter syndrome compared to 10 healthy controls. But what was interesting about this is that if you looked at those 5 that had gotten TRT versus those that didn't, their temporal lobes, which contain the amygdala, hippocampus, language areas, and so forth, were actually right on the mark in terms of its anatomy and structure compared to healthy controls. Really small sample, so don't get too excited about this. We have, yeah.
Was that at puberty or was that?
No, these are young adult men. So and at that time, it was a time where it wasn't necessarily usual practice. And as I mentioned, there's variations in whether you get TRT or not. And it just so happened that half of them had gotten TRT and half had not. So it was a convenience kind of retrospective sample, yeah.
Did they get TRT because their testosterone baseline was low, or just?
Don't know.
You don't know? Okay.
Don't know that.
That would be a variation.
Absolutely. It could have been, they were all low and just half of them got it. Yeah. This is a study that is not published yet. This is a study that we did in collaboration with Judy Ross at Nemours, Philadelphia, who did, as I mentioned, did this work where she gave low-dose androgen to 4 to 12-year-olds with Klinefelter syndrome. And among the outcomes that she looked at was whether their brains had different development depending on whether you got the oxandrolone or didn't. And you might remember that I mentioned to you that the hippocampus, this area underlying learning memory, is actually smaller in Klinefelter syndrome, and our group and others have all found pretty much the same thing. Well, we didn't have a typical control group in the study, but what we did find is that whether you got treatment or placebo made a difference in terms of the size of your hippocampus, okay, at time 2. So if you got the treatment, you had a larger hippocampus, interestingly, 4 to 12. Very low dose, not enough of a dose to cause puberty, or actually she has a poster that in some kids it did cause early puberty. And that size of your hippocampus was correlated with a memory function that was utilized. So provocative data, interesting, intriguing, small sample size. Don't get too excited about it yet. We talked about critical developmental windows. There are no studies, I mean, I can't believe this, but there are basically no studies that have tracked cognitive, behavioral, social, emotional brain responses to TRT around the pubertal time in Klinefelter. There's no studies, period. Crazy. Wouldn't you want to know what responds to testosterone? I want to know.
Isn't that what Dr. Tartaglia's study is right now?
The one that she's about to start?
No, the one that she just
She's ending, yeah.
She's ending. I don't think it's...
It hasn't been published.
Well, I'll tell you about what we're planning, and then you can tell me. I wasn't at Nicole's talk.
My son participated in that one.
Well, that's good.
He is tracking.
So that's good. But here's the really important thing. Again, getting back to this idea of critical developmental windows. Puberty is a time when the brain is expecting an increase in testosterone and androgens. If you get it later than normal, if you don't get a supplementation, whatever, it could potentially make a big difference in your outcome. So we need to know about this because of this issue of the brain's readiness to change its organization and function as a result of TRT. So new research is obviously required. Here's something else we don't know about. This is kind of a crazy idea as well that we don't know anything, which is environment. So we talked about this. Everyone raised their hand. It's nature and nurture. Everyone agrees on this, right? Okay. We hardly know anything about how nurture affects, and it's probably at least 50%. So is the school's profile fit to the learning needs of a child with Klinefelter syndrome likely to make a big difference? Yes. Is the resources available to a child for ancillary therapies and professionals, mental health professionals likely to make a difference? Yes. So there are all these things from the prenatal environment all the way up that are likely to make a difference. So I won't get into this too much. I mean, obviously you have both genetic and hormonal influences in Klinefelter syndrome, and there are all these different periods where it can make a difference, both the genetics and the hormones, prenatally, early development, pubertal development, all affecting outcome. And of course you have overlay on top of all of that, you have environmental effects. So we're proposing this study, and we're about to resubmit it for review. We got a good review the first time around, but it's hard to get funding these days. So we're going to try and address these gaps in understanding the neural effects of testosterone supplementation on adolescents with KS. What changes, improves, what doesn't? Does timing of TRT matter? What remains problematic after TRT? So it's not just important to understand what might change for the positive when you get TRT, but what doesn't change? So someone asked me this question in my a previous talk, which was kind of a speed dating version of this talk. Do I think language issues are likely to change with TRT in adolescence or to induce puberty? And my answer was no. I don't think it's likely, because those are very early organizational circuit challenges that occur, in the first year of life, in particular as exposed to sounds and speech and so forth. But might I expect executive function, social emotional function to respond? Yeah, I think there's a chance. Is it going to be completely, quote unquote, back to the level if they hadn't had Klinefelter syndrome? I don't know. I doubt it. But it's important to know, because then you know what you have left to try to deal with. Precision medicine. Optimizing hormone treatment in light of a better understanding of brain behavioral function. Developing new cognitive, behavioral, social, emotional treatments that take advantage of and target the specific profile of strengths and weaknesses in KS. So not just a standard cognitive computer-based training program that's kind of good for everyone. Can we develop one that's specifically good for Klinefelter syndrome? And imaging-based, and I told you I'd come back to this, and I will. So functional near-infrared spectroscopy. We are thinking about this in Klinefelter syndrome, and we are doing this in other conditions now. Hyperscanning. So most functional imaging studies using MRI, you look at a single brain's dynamic activity in response to something that you show or you ask them to do. Here you're looking at two brains and asking the question, what regions are correlated between those two brains when they're doing some sort of cooperation task or competition task or building task or precision task and so forth. Believe it or not, the level of correlation between two brain regions, specific brain regions, predicts your level of cooperation. And by the way, we just published a paper showing that the connectivity, the correlated regions between males and males and females and male-female dyads is different.
Wow.
You try put that in your pipe and smoke it, as they say. All right, neurofeedback. So biofeedback's been around for a long time with EEG and heart rate and so forth. But here we're not just feeding back these kind of lower level derivative measures of brain activity. We're looking at the circuits. Can we improve language, perhaps by facilitating awareness of and control over language circuits? Maybe. Can we improve social emotional function by increasing prefrontal activity under certain conditions? Maybe. We haven't tried this yet in Klinefelter syndrome, but we are doing this in other conditions right now and getting some promising results. Can you combine them? So if you do have a person with Klinefelter syndrome that has social emotional challenges, has trouble understanding other people, can you do this hyperscanning with neurofeedback and have them learn how to coordinate and correlate their brain activity with another person? I don't know the answer to this, but it sounds kind of interesting to do and provocative, and it's non-invasive, non-pharmacologic. Maybe it'll work in concert with other types of treatments, but we're certainly thinking a lot about this. One other thing that I like to say that's very important when we're dealing with conditions like Klinefelter syndrome is that, standard clinical trials, so let's say someone develops a drug and goes, oh, let's use this in Klinefelter syndrome. So we'll put half of them, we'll randomize half of the boys with Klinefelter syndrome to the drug, half of them to placebo. We don't know who's who. And then we'll measure it, we'll measure their response after 6 weeks if anything changes. Particularly, you're talking about social emotional function or executive function. My premise is that if you haven't, to that point, built the brain or neural infrastructure to accommodate those changes in behavior, it's not going to be likely to happen if you just give a drug. Even if that drug is the magic bullet, you've got to have the environmental conditions, the push, in addition to that, the challenge to see if, in fact, you can separate the two groups. And that's where standard clinical trials fail, I believe, in individuals who have congenital conditions. So I can talk more about that with Q&A if you want. I'm fortunate to be a member of the National Academy of Medicine, and they're very interested in studying sex differences. And here's the study that we're proposing. You can tell me if Nicole's is the same. I don't think so, though. Recruiting 60 boys with KS, 60 age-matched boys, 9 to 13 years of age at baseline. We're going to follow them at 4 annual time points, measuring all these aspects of behavior, emotional function, social function, multimodal brain imaging, hormone levels, assessment of puberty. And we don't have funding for this yet, But we are hoping that after the next round we will get funding from NICHD to do this study. If you're interested, we'd love to have you put your names in for potential participation, even if you have kids who are 6 or 7 at this point. They would probably age into the study by the time we would get started. So there's the contact. You would send Reiko an email or give her a call. Oh, thank you. So I'll conclude. Having a neurodevelopmental disorder can feel challenging. So I took this picture in Ireland. I had to get out of the car. I was driving. First of all, I was all sweating from driving, on the other side of the road. And I fortunately survived. And then I was passing this road. The roads in Ireland are really narrow. You see someone coming at you, you go, oh my, I hope we're going to fit. But I saw the sign, so I had to get out and take a picture with me. The car tipping over. So it can be challenging. And probably, again, because of my chosen area of medicine, I see parents who can be very frustrated, or even young men with Klinefelter syndrome who can be very frustrated with the way their lives have gone. And you probably have seen this, if we work together, if we can advance science and knowledge, anything is possible. I don't know if you've seen this, the skateboarding bulldog. I just love this video. I mean, who would have thought that a dog can learn how to skateboard, right? And so, I mean, if a bulldog can skateboard, I just think anything's really, really possible. I'm going to give particular thanks to some close colleagues of mine, and particularly the families who participated in our studies to date, and I'm going to stop there. Thank you. Happy to take questions. Yes?
What is the DSM? You said it. Could you explain it?
Sure. The DSM is the Diagnostic and Statistical Manual of Mental Disorders. And it's now in its 5th iteration. And it's a descriptive taxonomy. So if you go to see someone in the mental health field and you say, I'm having trouble sleeping, I have poor self-esteem, my appetite is lousy, and I'm not experiencing pleasure in my usual activities, they'll look through the DSM book and say, okay, you meet criteria this, that, 2 under B, 1 under C, it's been going on for this long, congratulations, you meet criteria for major depression. So it's a descriptive terminology, diagnostic taxonomy. It doesn't have really any corresponding validity in terms of how the brain develops or functions. But the terminology is used to communicate from one person to another. It does have some predictive significance in terms of how you respond to various therapies, medication or non-medication therapies, and it's the only way you can get insurance companies to pay for the work at this point. It's gone through several iterations. When I was first coming into the field, it was the DSM-3, and it had gone from the DSM-2, which was very what we call pseudo-etiologic. So it actually had neuroses and psychoses. If you have a neurosis, it's because something happened in your life at this point, so it's kind of these pseudo-explanatory things. DSM-3 was, okay, let's throw away all that stuff and let's just get descriptive. What symptoms and signs tend to cluster together in people who have mental disorders? And that approach has worked in many other fields, actually. It didn't work so well in psychiatry and psychology, unfortunately. So there's very little that maps from DSM to brain or genetics. You have a single genetic risk factor, as I was saying, for autism spectrum disorder. It not only can lead to increased risk for autism spectrum disorder, it can lead to risk for epilepsy without ASD, can lead to risk for intellectual disability without epilepsy and ASD, can even lead to increased risk for schizophrenia. So, yeah.
And it's on DSM-5 now, right?
We're on 5. Yeah, they invited me to be on the committee because the way they do this, they actually sit around in a group of presumably wise people, say, okay, this seems, let's change it for 6. And I said, believe me, I'm not the person you want to be on this committee to change it to the 5. The one real disease, this is a quiz, I didn't give you this quiz, but this is the hardest quiz question of all. What DSM-4 diagnosis actually has what's called construct validity, is grounded in neurobiologic truth because it has a clear genetic risk factor that's associated with an adverse outcome. Do you know? It's really an esoteric question.
Schizophrenia?
No, Rett syndrome. Have you heard of Rett syndrome? So it's a condition that affects girls. It's quite devastating. It's associated with developmental plateau and regression. 98% girls. We know more about the gene. So what did they do from the DSM-4 to the DSM-5? They got rid of it. That's right. So yeah, okay. All right. Other questions?